Hello and welcome to Primary Care Today on ReachMD. I'm your host, Dr. Brian McDonough, and with me today is Dr. Randa Sifri. She is Associate Professor of the Department of Family and Community Medicine in the Sydney Kimmel Medical College at Thomas Jefferson University. She's also a Director of Research in the department and serves as the Research Fellowship Director. Dr. Sifri, I wanted to talk to you today about cancer prevention, things primary care doctors can do to try to attack the issue and get ahead of it. And thanks, first of all, for taking the time to join us tonight.
Thank you for having me, Brian.
In the grassroots level, we're out there seeing patients day after day. What are the big steps we can take to try to help diagnose these things early and make a difference?
Well, Brian, there's many approaches that primary care physicians and clinicians can do to help with cancer prevention. I think one thing that providers need to recognize, and hopefully many of them do, that a recommendation to get screening for cancer by a primary care provider or clinician is clearly the single most influential factor on persuading someone to get screened. So recognizing, number one, that the recommendation by particularly a personal physician or provider, but in general from a health provider is really one of the most important things that we can do. There have been many changes over the last few years that have helped us really to kind of think about cancer screening and prevention in a more comprehensive way. And one of the things that's happened is that the focus now really on the patient-centered medical home and recognizing that many of the things that we do, including cancer screening and cancer prevention, need to be patient-centered, and trying to find a system where not all of the recommendations and not all of the care given for cancer prevention screening has to be done by the lead physician or the lead provider, that having a team approach and using staff members and using patient navigators, using the electronic medical record system that has the abilities to do prompts and have registries and be able to do reminders to patients. There's many new technologies and new approaches out there that have helped us to do a better job with that. Another kind of new kind of change in the area has been the introduction of the Affordable Care Act, and the fact that all insurances, new insurances that came about from the Affordable Care Act now must provide preventive care without a copay to their patients, so that patients now with those insurances can get screening colonoscopies, screening mammograms, screening pap smears. All of the preventive care services should be covered by the Affordable Care Act if they received a high rating from the U.S. Preventive Services Task Force. And I think the last kind of major change in the last few years has been kind of the development of more accountable care organizations and pay-for-performance insurance plans, where many practices are now really encouraged and incentivized to do better preventive services, particularly in cancer screening as well, with mammograms and colorectal cancer screening being very important as far as the measures that are being looked at and that are being incentivized.
So you look at all of those things, and people are in practice, and you look at the EMR as a valuable tool. What are some creative ways we can use the EMR, and especially as we're getting a little more sophisticated with it?
There are many different EMRs out there, and some are much better than others. And there's still, many practices that haven't yet, implemented EMR. So that, I think that trying to get people to get on an EMR and encouraging meaningful use of EMR is very important to begin with. I think probably one of the biggest tools that could be available through the EMR is a prompt. So, there are most of the EMRs have preventive care flow sheets, and they are able to, provide prompting for providers to remember when somebody is due for a cancer prevention activity, or to be able to identify the patients that have not yet been screened or haven't had a conversation about that. I think the difficult thing nowadays is that practices now are really responsible for all the patients that are in their panel, even if the patients are not coming into the practice for an office visit, so that the EMRs can be incredibly helpful in identifying patients who don't come in very often or come in much at all, and identifying how we can reach out to them, and having lists and addresses, and being able to just electronically develop reminders and educational materials that can be sent out to patients.
And you're at Jefferson, which obviously is a leading medical center, but like many medical schools and institutions, you may have a little bit more degree of sophistication with an EMR, and you're using it for research. What are some of the things docs in the community can look forward to that you see from the work you're doing?
Yeah, I think that, one thing that we're finding that actually the EMR has not been very helpful with, and in fact has been not as good as some of the paper chart systems, was how to identify patients that were at our high risk. So identify patients that have a family history. Many of the EMRs out there now don't allow for a genogram to be generated from the family history information that's being entered into the computer. I mean, many times it's just a narrative form, and that provides a more difficult approach. But having, and for community docs as well, whether it's electronic-based or paper-based or even smartphone-based, to have tools that allow them to identify patients that are high risk and to have, the ability to understand if a patient has a family member, first-degree relative that had a colon adenoma, diagnosed before the age of 60, that patient's at higher risk and needs to be treated a little bit differently. So I think, being able to access, the support systems, the decision aids, and things like that from the EMR is probably one of the biggest things that community physicians, as well as academic physicians as well, will benefit from the EMR.
If you're just tuning in, you're listening to Primary Care Today on ReachMD. I'm your host, Dr. Brian McDonough, and with me is Dr. Randa Sifri from Jefferson, and we've talked a little about EMR, but I want to get more into the role of primary care and early cancer detection and prevention. Right now, in prevention, what are the top cancers we can look at where we can make a real difference by diagnosing it early?
Amazingly, relatively few. So that if you look at the cancers that clearly have screening recommendations, and we'll go through for men, the one that's actually not clear as much is prostate cancer. That's the one that there's controversy over whether or not that's the cancer that should be screened for. The U.S. Preventive Services Task Force gave it a letter D, which meant that for patients that are at average risk, they are not recommending cancer screening. The American Cancer Society, however, does recommend a shared decision-making approach towards prostate cancer screening. But for the other cancers, for colorectal cancer screening, that one's remarkably in agreement between among different organizations, so that recommending a number of different types of colon cancer screening test options are reasonable. So a colonoscopy could be recommended. Again, this is for all men and women actually at the age of 50 if they're not at high risk. A stool-based blood test that's done at home, preferably a fecal immunochemical test or a very highly sensitive Guayat test would be also very appropriate. There are still the flexible sigmoidoscopy is still recommended. Other tests that are recommended by one and maybe not the other quite as much. Barium enemas are still recommended through the American Cancer Society. And some of the newer tests like CT colonography or virtual colonoscopy is recommended. Another cancer that's very little controversy about it is cervical cancer screening. So that's recommended by almost all the organizations. Women between the ages of 21 and 30 should be getting pap smears every 3 years. That's a decrease in interval from recent guidelines, but that's consistent across different organizations. And then women between the ages of 30 and 65 should be getting them every 5 years, as long as they're also getting an HPV test along with the pap smear. The next one would be breast cancer screening, so getting some controversy between different organizations. The task force has a little bit different approach for women between the ages of 40 and 49, but still it's recommended to have that discussion with the primaries, and then when patients reach the age of 50, they should be recommended to get mammography screening every 1 to 2 years. The American Cancer Society recommends that every year starting at the age of 40. And then the last cancer that's actually one of the newer ones to have a screening guideline is for lung cancer, and this is a pretty radical change in guidelines. It's recommended that all patients, and this is both the American Cancer Society and the U.S. Preventive Services Task Force, now recommends that patients that are 55 to 74 years old, or 80 if it's the task force, who've had a 30-pack year history or have quit within the last 15 years, still smoking or quit, should be getting annual low-dose CT scans to screen for lung cancer, and that received a B recommendation from the task force, and that's a relatively new guideline that many providers are not yet terribly familiar with or haven't quite incorporated into their practice yet.
Now, is that where you would say to turn for the primary care doc who's out there? You would say USPSTF, or is that where you would say to go for the recommendations for general information, specialty societies? What do you suggest?
That's an excellent question. I mean, one thing that providers should realize is that the Affordable Care Act requires that any U.S. Preventive Services Task Force guideline that receives an A or a B should get covered without a copay being instituted for the patients that have insurances covered by the ACA. So the task force tends to be a bit more conservative and don't quite go as far sometimes as specialty organizations, but the number of studies that have come out that say that looked at this and have found that primary care providers often follow the American Cancer Society guidelines. So that I think either of them are certainly reasonable. One tends to be a little bit more conservative than the other, but they in many times they actually agree with each other, so the difficulty is not as hard to decide.
What about preventive things that patients can do that we as primary care docs should look at and say we should be advising our patients, changes they can make, lifestyle, exercise,
Absolutely.
Those sorts of things?
Again, it's been estimated that maybe anywhere from 70 to 90% of cancers could be prevented by lifestyle changes. So probably the three biggest ones that we can certainly assess in our patients and then counsel them on changing behaviors if they're positive. One is, by far the biggest one, is smoking, and it's estimated about 30% of cancers have some connection to tobacco. So helping patients stop smoking, there's a lot of different ways to help patients now, both pharmaceutically and with counseling types of interventions. Another major preventive area that we can work on with our patients is moderate alcohol use, trying to decrease excessive alcohol use. There's many cancers that are associated with alcohol use. And then the other big one actually is obesity, and many patients in particular don't realize that being overweight or being particularly obese has a tremendous risk factor for cancer. So helping patients with weight loss, with increasing exercise is very important. And then kind of another one to certainly keep in mind, although probably not quite as high as the other three, is really to help people understand, the risk of sun exposure and, and the use of sunscreen, especially this time of year.
Yeah, that's a very important point as well. When we're looking at lifestyle, we look at the medications that are out there. What about research from our perspective? Again, are there big strides in the past few years? Anything you've seen really exciting in treatment of cancer?
Yeah, I think as far as treatment, there's all kinds of things with treatment. One of the certainly a big rise in many of the health systems in general are trying to develop programs that deal with personalized health care, which is really more kind of genetically based interventions to help with treating cancer. But one of the things more with screening and more at the primary care level that has really been helpful, and I think a lot of practices have begun to incorporate into their day-to-day work, is the use of patient navigators and health educators and other kind of outreach workers, staff within their office who are kind of cross-training and learning different skills on how to help patients get screened or make behavior changes. That we're finding, particularly in the research that we do here at Jefferson, that there's been a particular advantage of navigators in having kind of personal contact with patients who have experienced disparities with cancer. So that particularly racial and ethnic minorities who have not kind of seen some of the gains in cancer screening and cancer treatment rates that other populations have, that we found that the use of navigators has been incredibly helpful.
We only have about 35 seconds or so left. If you were to give a final tip, guidance for primary care doctors out there of what they should do, what would you say the biggest things to do are?
I think one is to, again, recommend that their recommendation for a patient to get screened has incredible influence, and they need to remember that and recognize that. Because there are some controversies in cancer screening, that they should come up with their own policy. Don't redebate it in your head every time. Come to a decision about how you want to approach a particular cancer screening recommendation and be consistent with how you approach patients with that. And then finally, I think that, having a team approach and using your office staff and using other folks to help identify where patients are and getting screened or making lifestyle changes, and using people other than yourself to try to get this done, because a team approach is truly one that's probably the best to use for this and for many other types of care.
Dr. Randa Sifri, I'm afraid we run out of time. I want to thank you so much for joining us and sharing your insights on primary care today.
Thank you so much, Brian.
This is Dr. Brian McDonough. If you missed any of this discussion, please visit reachmd.com/primary care today to download the podcast and learn more on this series. Thank you very much for listening.